Okay, now we're going to do some case reports to the patient. And I start with this. I was the editor-in-chief of the journal Visacos, and then I received a few years ago this article, and it was from US. They did 30 volleyball players, professional volleyball players. They did an MRI of the shoulder. They were asymptomatic, and there was pathology in 100%. And it was pathology like glenoid, anterior ligament avulsion, slap lesion, partial cuff lesions. So really serious lesions that normally would need repair if symptomatic. But all of them were asymptomatic. So I wrote this editorial, treat the patient, not the MRI. We were talking about it this morning. Listen to the patient is always right. And what do I mean with it? That the history taking is most important. And those volleyball players, they didn't have any complaints. So the history was vital because they didn't have complaints, so there's no surgery indication. Because we know in the shoulder, when you operate those lesions, only 80% come back. Yeah, so you turn a healthy patient, into a patient that cannot continue his career if you would treat the MRI and not the patient. And this is then also, of course, true for the knee. That's also true for the ankle. And I was at this congress of the Dutch Medical Association a few years ago, and in the audience we were with 2,000 physicians, and we were asked a question. There was polling of, we all had, we could poll on our telephones. If you were a patient in 2040, what would you consider most important? And our answer was being seen, being heard, being regarded as a human being, and not just a collection of laboratory results and MRI images. And if we want that for ourselves, we should also want it for our patients. So again, listen to the patient. The patient is always right, even if he's wrong. I mean, if a patient comes to you with back pain and wants a surgery, I mean, he is right, he has the back pain. It's up to us to tell the patient that there's no indication for surgery. That maybe it's mental or whatever, but the patient is right in that he has his back pain, or in our case, the ankle pain. So what I'm going to do is go over a collection of patients, and like I said before, the history taking is the most important. So in your diagnostic schedule, the history taking is most important. Then the physical examination, and then the MRI or the CT or whatever. So when the patient already comes in, it's a man or a woman, or you know the age, and then on the basis of the history, you'll make a diagnosis. Already, a working hypothesis, yeah? So this patient, a female, 30 years, she comes in, she didn't have a trauma, and she has deep ankle pain. So what's your diagnosis? What's your working hypothesis? 30 years, no trauma, she has deep ankle pain. You already have an idea. Impingement.
Probably osteochondral lesion.
Osteochondral lesion? Maybe an osteochondral lesion, deep ankle pain? I think you would think of an osteochondral defect with this age, 30 years old, no trauma, osteochondral defect. On the physical examination, no recognizable tenderness on palpation, basically a normal ankle, normal x-ray, still the diagnosis is the same? Yeah, osteochondral defect, you can have a normal physical examination. Eh? There's no specific findings usually on a patient with an osteochondral defect. Normal x-ray doesn't rule out an osteochondral defect. So, who would make an MRI? Only one. So you are all, yeah? Who would make a CT scan? 2, yeah. Yeah, so the reason to make an MRI is to see if there is bone marrow edema. Yeah, that's what we can understand. When we look at an MRI, we see bone marrow edema. Bone marrow edema is pain. Yeah? So the MRI is to confirm. If you're uncertain that's an osteochondral defect, you still think it's a impingement, for example, then the MRI will help you with bone marrow edema, yes or no. The CT scan is for preoperative planning. Yeah? So if you're convinced that this is an osteochondral defect, which needs treatment, then you can go straight to a CT scan. Yeah? So if you're uncertain, you first make an MRI, you see bone marrow edema, okay, it's an osteochondral defect. You want to treat it, you make a CT scan. If you're already certain, you make a CT scan straight away, because it's deep ankle pain, you see the cyst, and you will go for treatment. You will go for bone marrow stimulation. No PENF, we heard, no addition of any biologicals, just the bone marrow stimulation. Next patient. It's a patient, a male, 35 years old. He comes in with superficial ankle pain. What's the diagnosis? Impingement. So your working hypothesis is impingement. Yeah? You make your physical examination, recognizable tenderness on palpation anterior joint line. Does it confirm the diagnosis of impingement?
Yes.
Yes, that's what you expect. That is basically, it's confirmed by the recognizable tenderness on palpation. And you could also say it's now anteromedial impingement. Yeah, because the pain is on the medial side. So the diagnosis now is anteromedial impingement. Then you make an X-ray. Now the diagnosis is anteromedial bony impingement. Yeah, so every step further you fill in your diagnosis. MRI or CT scan? Who would make an MRI? We want to go for surgery. The patient is such that we want to go for surgery. Who would make an MRI? Yes. Why you would make an MRI?
I want to know first the color pathology negative in the brain. And doing at the same time in the operation,
Yeah, so you can make an MRI to rule out other pathology, to make sure that there's no cartilage lesion, that there's no other lesion. So basically it is to confirm that there's no other pathology. Yeah? Who would make a CT scan? Do you know why would you make a CT scan?
I suppose ruling out that I won't forget any fragment of any.
I think that's a very important remark that Gino makes, because you can have there on the medial side, there. Oh, this is how it works. Ah. I'm not good at it. Anyway, there on the medial side, under the medial malleolus, it could be that there's a small fragment also on the tip of the medial malleolus. And if you don't know that there's that fragment, you will not see it during your arthroscopy, because it's in the soft tissue. So for your preoperative planning, again, CT scan is always for preoperative planning, to know exactly where is the osteophyte, are there still loose fragments. So in this case, with this configuration of osteophytes, I think CT scan would be a good idea. Yeah.
You prepare thin slice CT scans.
Yeah. Yes, thin slice CT scan, and you have to instruct your radiologist how to make the sagittal and the coronal plane, because the sagittal plane he should make parallel to the lateral talar facet. Yeah, and then the coronal should be 90 degrees on top of it. Because if they just do random the sagittal, then you can that's for the osteochondral defect mainly, then you don't see the complete talar configuration.
Sorry, I can ask a question too here I am.
Sorry.
I can ask a question about CT. Some centers in Europe just take contrasted CT about osteochondral lesions, about containment. Do you use contrast in your CT?
Yeah, that's a very good question. I always hate to get a patient from Belgium or from France, because they always do contrast in a CT scan. And I think it's terrible. It's just money making for the radiologist. Because if you put in contrast, you don't see loose bodies any longer. Okay? So they do it because they say then we will see if there's connection in an osteochondral defect between the joint and the cyst. But if there's no connection, it's false negative.
Right.
Because there's always a connection. So I don't see any reason to do contrast in a CT. I even think it is negative, because you don't get that fine information that you want from a CT scan. Because the secret in chronic ankle patients, for me, is small bony fragments, a small ossicle. The patient can deal usually with soft tissue problems around the ankle, but not with the bony problems. So you want to know exactly what is the bony problem.
Thank you.
So we do the surgery, we remove it, and that's it. And of course it comes back, but that is not an issue.
Would you prefer an AD view instead of the view?
Yes. Yeah, you could do the AMI view, but in this case you already see the osteophyte. So basically, if you have anteromedial impingement without seeing osteophyte, then the AMI view is very helpful. But the CT scan, if you make a CT scan, then make a 3D reconstruction for this.
I'm just not the lateral view, I'm not talking about the CT, I'm talking about the instead of lateral view, not instead of CT.
Instead of the?
Instead of the classic lateral view, not instead of CT.
Yeah, I understand. So you make the lateral view, and if there was no osteophyte on the lateral view, then you could make the AMI view, and then you would see the osteophytes on the medial side. And then still, maybe you would make a CT if you're uncertain if there's still loose bodies under the medial malleolus. So, patient, also 35 years of age, lateral ligament rupture 7 years ago. He has deep ankle pain, but on physical examination, he has recognizable tenderness on palpation. So there's a conflict here, yeah? Because he has deep ankle pain, so you expect an osteochondral defect on this age. But he has also recognizable tenderness on palpation on the medial side, and the anterior drawer is slightly positive. What is your diagnosis? What is he suffering from? Deep ankle pain, but recognizable tenderness on palpation, on the arrow. Yeah, he has this avulsion, and yeah, maybe it's that avulsion that you see. But what do you see also on the... Yeah, on the lateral shoulder, the lateral shoulder. So I think everybody will agree that we make an MRI, huh? Just to make sure that the deep ankle pain is not from MRI, no bone marrow edema. So if we go for surgery, would we go for the lateral talar cartilage problem without bone marrow edema? Who would address? Nobody. No, I think when the MRI shows no bone marrow edema or the SPECT CT is negative, then this cartilage problem does not give him the problems not to justify a treatment like bone marrow stimulation. What about we go for surgery, we're going to remove that fragment. Can we do it arthroscopically? Yes, we can. It's a very nice surgery. I mean, it is quite a large fragment, of course, but it's very rewarding to do it arthroscopically. Do we do something to the drawer, to the laxity? Who would also do a ligament repair? Who would not do a ligament repair?
If there is a laxity, we should do it.
You should do it? Why? He has no complaints. He has no instability. He has just laxity. You still do it?
In surgical examination under general anesthesia,
It shows 1+ drawer.
I detect an laxity and instability in the ankle. In my daily practice, I want to treat also the instability because
The laxity in this case. He has not instability, but he has laxity. And non-symptomatic
Maybe
laxity.
global instability. We don't know.
Global
We
instability.
we didn't scope. You scoped it, and maybe
No, the rest is okay. The syndesmosis is
global
okay.
instability.
Medial, it's okay. It's just 1+ drawer, and it's non-symptomatic.
ATFL sometimes problem and maybe It is not symptoms now, but it's could be problematic after months or years.
Could be. Could be. But Gino and I, we treat a lot of professional soccer players, and I think 50% of them are legs. Huh? And we don't treat them because they are, their muscular status is such that they don't have instability. So, yeah, there's
I am talking about the regular people.
the regular patient,
The footballers and the athletes should be could be strong and stable ankles with the muscular support.
It's possible, and you have to explain him then that you are going to do it. And nowadays with the arthroscopic treatment, because that's the issue. When you have to do it open, then you do arthroscopic, this medial fragment, and then you have to make an incision and do a lateral ligament repair with 6 weeks of immobilization for something that the patient has no complaints of. So you must really think and explain well to the patient. I mean, it might be different if it's an osteochondral defect that you have to treat, because the combination of laxity and osteochondral defect, then you might argue to do the ligament repair at the same time. And I nowadays do it. I do it arthroscopically. And that, I think, is an important to do. And here it's an option, but is this another patient? Yes, another patient. But he's still 35 years old, also had a lateral ligament rupture 7 years ago, deep ankle pain, no recognizable tenderness on palpation, also has a slightly positive anterior drawer. What is the diagnosis? What can be the cause of his pain? Deep ankle pain? Well, maybe osteochondral defect. We can rule it out with MRI. Okay, we make an MRI. MRI is negative, so it's not an osteochondral defect. Still, he has deep ankle pain, no recognizable tenderness on palpation. If you look carefully, you see this little ossicle. Yeah? So what I want to highlight with this patient is you have a patient, comes to you, deep ankle pain, you expect an osteochondral defect, no recognizable tenderness on palpation, okay, osteochondral defect, you make the MRI, it's not an osteochondral defect. Then you have to start again with your history taking and physical examination. And you see on the X-ray, you see this bony particle, so you have to go back to the patient and palpate a little deeper, because you don't do that initially. But you palpate a little deep, and now he says, yeah, this is my pain. So an ossicle like this can give deep ankle pain because it's inside the deltoid ligament, and you really have to press quite hard to provoke his pain. So what I'm wanting to say with this is that if there is an unexpected finding down the road, you have to go back to your history taking and physical examination to see if what you see on the X-ray in this case is the cause of his complaints, or when you have an MRI, if that unexpected finding is really the cause of his problem. Male, 35 years, lateral ligament rupture 7 years ago, recurrent giving way. Ankle pain, recognizable tenderness on palpation on the lateral side, anterior drawer is positive, X-ray is normal. We go for surgery.
I want to know about your treatment because there's also medial pain, maybe due to the previous
No,
picture.
there's no medial, no tenderness on palpation on the medial side.
The previous patient, I mean.
The
Not
previous
this one.
patient.
The previous one. Okay, we are dealing with the avulsion of deltoid. Now in ATFL, anterior rubber sign is like positive. Is it sensitive to repair the deltoid or avulsion? Do anything for the deltoid or not?
No, it's not a rupture of the deltoid. It is not a rupture of the deltoid. The deltoid is attaches more to the outside, the medial side. If you go in, you will recognize this on the tip of the medial malleolus. Maybe there's a few fibers attached to the deltoid ligament, but you don't make laxity by removing this fragment. Even the big one that we saw before, I would not do anything to the deltoid ligament.
Thank you.
But this patient, recurrent giving way, ankle pain. Is ankle pain enough in the history taking? No, we want to know if it's deep pain or superficial. Okay, it's deep pain. So we make a MRI and we see this large cystic lesion as the cause of his pain, and he has the laxity. So in this case, we will repair the ligaments and we will treat the osteochondral defect. I don't know how, because it's quite large. I want to skip that part, because that will be a long discussion, and that's not the topic of what I want to go with you through. Male, 42 years old, ankle fracture 17 years ago, progressive ankle pain since 2-3 years. What's the diagnosis based on the history taking? Arthritic ankle. Ankle fracture 70 years ago. Pain since 2 years. That's your hypothesis, that he has arthritic ankle after an ankle fracture. But then we go for the physical examination and he has recognizable tenderness on palpation on all those areas. So what's now the diagnosis? But your working hypothesis. By definition, anterior impingement, because he has recognizable tenderness, in an arthritic ankle. Yeah? That's now your working hypothesis. Because based on the diagnosis, on the history, it is an arthritic ankle, probably with osteophytes, which give him the anterior impingement. And yes, this is his X-ray, so it confirms your working hypothesis that he has an arthritic ankle, degenerative ankle with osteophytes, with anterior impingement.
Also posterior.
Also posterior. So we go back to the patient, do the posterior impingement test, is negative. We try to palpate, it's negative. So he doesn't have pain on the posterior side. You go back to the patient, do you have deep ankle pain? He says, no, this is my pain when I press. What to do? Shaving the osteophyte, but he has an arthritic ankle. The laxity. He has...
sorry, it's candidate for arthroplasty, I think, because there is a narrowing about the joint.
the narrow,
General, not just impingement.
no,
I think degenerative joint disease
Yeah.
started.
he has degenerative joint disease, stable ankle, there's no drawer.
So I don't think it can be useful to take the osteophytes.
So what would be
Not work.
what would be your therapy?
Physical therapy first, but
Yeah,
it's
we give...
really, I encounter these patients. These are really, really tough patients. And then though the procedures, sometimes I do arthrodesis. I do not have an option in my country, arthroplasty, but this is candidate for arthroplasty.
For arthroplasty, 42 years
In
old,
the future.
or a fusion. Or first physiotherapy. Okay, we first give physiotherapy, he comes back half year later with the same complaints. So now...
Maybe scope. Maybe first I will scope it, but I'm sure it will be deteriorate these patients.
And what is the reason to scope? What is your objective? What do you tell? We do a scope?
Diagnostic.
Huh?
Diagnostic.
Diagnostic.
I want to see the cartilage.
Okay.
How is the cartilage?
Okay. Okay. Other options? Maybe get a CT scan. Okay, we make a CT scan. You see some... I don't know. We didn't make a CT scan. So I cannot tell you what shows the CT scan.
stage of osteoarthritis. Stemming it's advanced, looking at this one, the midway and mid stage of osteo. Shall we think about the preventive measures to prevent the progress of the osteoarthritis or?
So, but he asked for treatment. He asked for treatment first now.
Yeah.
He wanted to be treated because he has pain.
So,
Huh?
he should remove the impingement.
And what do you say to the patient? Okay, we're gonna take the osteophytes. What do you tell him?
I will tell them at the beginning we will remove the bone and the soft tissue over there, which causes the problem at the beginning. Probably by the time the spur will relapse again, and then we should check for his symptoms, if it's symptomatic or not. And if there is any kind of cartilage lesions when we scope, we can treat them at the same time. And then we should check for the progress of the patient.
Okay. Treatment
Sorry,
of the...
instability is excluded in this patient. Instability.
Well, he has a slight laxity. Sorry, I said he has no laxity. He has a slight laxity. To make it a little bit more... Slight laxity, a little bit. Not 1+, it's just slightly
But
lax.
maybe osteophytes.
Huh?
Osteophytes maybe take it.
Yeah, the osteophyte make him stable.
It mimics.
If you remove the osteophyte, the ankle is
stable ankle, I think.
more unstable. But to go back to, okay, so you say we're going to do arthroscopy, we take away the osteophyte. What percentage of chance you give him for a success?
Not that much. Probably
much?
80% the osteophyte will occur again. And
No.
I don't know the cartilage lesion, the extent of the cartilage. So if to give him the chance, or we should know the extent of the cartilage lesion at the beginning.
Yeah. Well, this patient clinically has anterior impingement, yeah, and in an arthritic ankle. But we ask him, he has no deep ankle pain. So he has cartilage damage, but he doesn't suffer, possibly, because it's not always difficult for the patient to differentiate. So he might still have the deep pain when you remove it. When you remove osteophytes, when you treat the impingement in this type of patients, and I told it this morning, you have a 50% chance of a good outcome, which lasts over time, 5 to 7 years, 50%. Okay, so we tell the patient, well, you have a 50% chance. And he says, no, that's not good enough. What's the alternative? And the alternative is an arthrodesis or a prosthesis. Then he says, do me the arthroscopy. And then if you give the patient a proper prognosis and you say it's only 50%, then even if he is unsuccessful, he will still be happy and not point at you, why did you do this surgery? So I think it's important to know the prognosis of this type of surgery and tell the patient honestly.
Yeah, in such, excuse me, in such cases with Ditchmat arthritis, what is your experience with distraction arthroplasty after removing the impingement? Can we not increase the survival chances?
I'll answer it. So this is post-operative, the patient, and now we could do the distraction, if you feel like it. But I didn't do it, and it is now 20 years later, he still has a good result. So I'm not in favor of this distraction arthroplasty. It's a lot of bother for the patient, and I've never been doing it. But there is some publications, of course, from Utrecht, van Roermond, who show that that's a possibility in more advanced arthritis. But just to show you that if you have a patient that clinically has anterior impingement, like this patient, no deep ankle pain, recognizable tenderness, it's an arthritic ankle, you tell the patient you have a 50% chance of a good outcome, you remove the osteophytes, and you have 100% happy patients, but only 50% have no pain. This is a patient which was sent to me from Russia recently. So I haven't seen the patient, so we have to try to solve They sent me a video, which I will show you. This is the history. It's a young 20-year track and field athlete. After a minor inversion injury of the ankle joint more than 1 year ago, he had clicks in the ankle. Clicking is accompanied by severe discomfort and moderate pain. Since then, he had a number of operations in the ankle joint. And maybe I showed first the... This is the video that they sent me. They performed an arthroscopy with excision of the post-traumatic scars, resection of the basset ligament, resection of an exostosis on the talus and the tibia. After subsidence of the postoperative edema, the clicks resumed. Then the excision of the peroneus tertius, so already 3 surgeries. Unfortunately, after that, the clicks didn't go away. You all know those patients with clicks. We get them. What do we do? He already had 3 surgeries. What is the cause? How do we solve it? Any idea?
Probably the anterior tendons.
The
problem is the tendons of anterior compartment.
and
Which one I don't know, but probably the tendons of anterior compartment.
okay, and how do we solve it?
It's really hard to say. I have 2 patients like this still clicking.
And
One of them is my colleague's wife. I couldn't find. I did MRI, dynamic ultrasonography. I did injections, still clicking. I didn't find anything. I discussed with radiologists. They said don't scope.
don't
So
scope.
I'm still waiting.
You're still waiting. No surgeries yet.
Yeah, yes, no, but probably this patient has a problem in tendons of anterior compartment, I think. Maybe rupture, partial rupture or another thing.
So resection of the anterior tendons?
No, release, just release.
Okay. The first patient that I had many years ago, I think it was before your times, you know, but maybe he was from The Hague. Maybe you've seen him. And then I did 4 surgeries. And after each surgery, he came back, and then with the sweat on his forehead, and he said, "It's still there." That was my first experience with this type of problem. And I think I mean, a lot of you can get these clicks in the fingers, huh? And that is probably caused by a vacuum phenomenon. You pull a vacuum and then the air goes back and that gives the explosion. And if I turn my head 20 times, I have a click in my neck. Probably if you do it, maybe with you it needs 50 times, you get a click. And then if you do it 1 hour later, the click is still there. If you do it 1 day later, the click is still there. But if you forget it for a week and you do it, you need those 50 times again. So most probably this is because, and you see it there, rotating the foot inward. So he makes this movement. Yeah, he rotates. And that's not a normal motion. I always say to my patient, don't do this motion. So I gave the advice to the physician that sent him in. I said, let him stop with this movement. And then the click stopped. So that's the advice to your patient. See what he is doing wrong. What causes the click? Probably it's rotation.
You know, that patient's mental issue is not normal, I think.
Exactly.
So I decided to scope that patient, but my friend, radiologist, don't touch. Said, and I said, no, I will not do. I didn't know what she do now, but probably 3 months after, I decided not to operate.
There was...
Yes, you are right. She is rotating.
She rotated. That's the problem. It is those abnormal movements, like when you do like this, it's also, it's abnormal. And you have those patients with those clicking shoulders. I mean, there's something, you are concentrated on something which you shouldn't do. But I presented this recently also, and then someone in the audience said, why don't you make a echography? And I thought that was a good idea, to do an echography and to see when does it happen. And then maybe you see something, but regardless that, just stop with the rotation. Well, this is obvious. This is another reason for a click, the peroneal tendon dislocation. Just the last one, and it's just to provoke the discussion or the thought on peroneal tendon length rupture. You see the peroneal tendon length rupture, and the prevalence of non-symptomatic tears is 25%. So at the end of the life, there is tears in the peroneus brevis, 25%. So 1 in 4. And 99.9999999% will never have complaints. So most of those tears are asymptomatic. So which tears then, why does a tear become symptomatic? I think it's a very interesting question. Why? Because if we know why this tear becomes symptomatic, we know how to treat it. Because now we just suture it, or we resect it, or we do a tenodesis, but yeah, I don't know. But maybe the solution is in, like we have with the Achilles tendon, the tendon itself is aneural, so the pain doesn't come from the tendon. There's no nerve endings in the tendon. It's the repair of the body, the neovascularization, and with it the neoinnervation, that provides the pain. So this is what you see with those peroneus brevis tears. You see the neovascularization on the tendon. Here's the tear. And there's the neonerves with the vessels. So maybe if the patient starts to repair, try to repair, that starts the pain. And when the patient doesn't repair, it's asymptomatic. It stays asymptomatic. That's how it works in the Achilles tendinopathy. Maybe it's the same in the, and then you just have to scratch the neovascularization endoscopically off it. You do a denervation and then it's okay, and you don't have to suture. I haven't dared to be doing it, but it's an interesting thought, isn't it? And I think with that, one last case, sorry. This is a patient 2 weeks ago had well, I don't know if he had any trauma, not really. But he's uncertain with walking. And he can do the one leg, he can do the heel raise like this, but he can do the one leg heel raise on the right side and not on the left. So what's the diagnosis? Uncertain trauma 2 weeks ago. Uncertain with walking. He cannot do the one leg heel raise with his left ankle. What's the diagnosis? A young man.
There's a problem about Achilles tendon, I think.
Achilles tendon rupture.
Probably.
Yeah, Achilles tendon rupture. Because you cannot do the one leg heel raise when you have a Achilles tendon rupture. And of course you do the Thompson test to maybe an echo if you want it, but it is just the one leg heel raise, which I believe is important for an insufficient Achilles tendon, for the diagnosis for an insufficient Achilles tendon. And with that, I like to finish this.
Thank you.
This part. You're welcome.
Now, is there any question from audience?
I would like to ask about any role of soft tissue ultrasound and
If there's a role for? No, in my practice, no. That doesn't mean that there's no place for it, but I don't, I never make use of it. I want to see myself and not rely on what the radiologist says. But if you have a reliable radiologist, then yeah, I think it's for dynamic, for example, for the syndesmotic laxity, I think it can be very helpful. But I don't do it.
One more question.
Last question, maybe. I wonder, this question is also for you, Doc. You still continue to do the osteochondral autography for knee. There is where you draw a line between the iliac crest grafting and autograph. You still continue to do the osteochondral autograft on the knee.
Yeah, well, yes, I do the osteochondral autograft. I don't do them a lot because I do the AP sealer, the metal implant. And it doesn't mean that there's no indication, but when you are doing a series of patients, then that is your solution, if you understand what I mean. The problem in general with the osteochondral defect, knee to knee, it's about what you were showing, 6%, 7, 8% donor morbidity, but knee to ankle, in the literature, it's about 20% donor morbidity. Probably because if you do knee to knee, the patient already has knee problems, so he doesn't notice the deficit from the graft, but when you have a virgin knee and you transplant, then that is probably less profitable. And there's also 6 publications on low volume centers, so when you do less than 10 of those grafts a year, then the morbidity goes up to 50%. And most of us will not do a lot of those. So then you have to really take into account, if you do knee to ankle, low volume center, that the chance of knee problems is quite relevant. And then maybe an allograft, if you have access to allograft, is probably better.
I understand. Thank you.
Okay, thank you everyone. Lunch break now.